So picture this. You're sitting on that crinkly paper on an exam table.
Oh, yeah. Everybody knows that sound.
Right. And the room has that unmistakable, sterile rubbing alcohol smell.
Yeah, that smell alone spikes the heart rate.
Exactly. And then the doctor pulls out a medical needle. And honestly, it rarely matters how old you are or like how completely you understand why you need the procedure. Your brain just instantly zeroes in on that sharp, sudden pinch that's about to happen.
It's purely instinctual. I mean, we're naturally hardwired to perceive a physical puncture as a threat.
Right, which makes total sense. But what if I told you that you could literally trick your spinal cord into just ignoring that puncture wound?
Yeah, using something as simple as like an ice pack or a $20 vibrating massager.
It sounds totally like a sci-fi biohack, right?
It really does. But our biology is actually weirdly wired to allow for this exact kind of interception. The neurological pathways that carry that threat signal, they can basically be jammed.
And that actually brings us directly to our mission for this deep dive. We are tackling a very specific, practical question for you today.
Yes, the big question.
Can a vibration anesthesia device or a localized cooling system be used to blunt the sharp sensation of anterior wall microinjections?
It's a very specific procedure, but it affects so many people.
Yeah, it really does. And to figure this out, we're pulling from a really fascinating stack of sources today. We've got clinical trials on pediatric dental patients, meta-analyses from the Journal of Clinical Anesthetic Dermatology, plastic surgery guidelines, and even official medical policies from Blue Cross Blue Shield.
Which is great because it gives us a really holistic view, from the biological mechanics all the way to insurance guidelines.
Exactly. But before we get into figuring out how to actually stop the pain, we need to establish what we're even targeting here.
Right, the anterior wall.
Yeah. So in a medical context, when the sources talk about anterior wall pain, what exactly are we looking at?
So we're basically talking about chronic abdominal wall pain. The Blue Cross Blue Shield policy documents we reviewed, they specifically highlight conditions like anterior cutaneous nerve entrapment syndrome.
Okay, wait, let me try to visualize that. The anterior wall is essentially the front of your abdomen, right?
Yes, exactly.
Encompassing the rectus abdominis, which is like the muscle we all usually call the six-pack.
Yep, that's the one.
So a nerve entrapment syndrome means a nerve is literally just getting stuck somewhere in that muscular structure.
Yeah, pretty much.
Yeah.
If you think about the anatomy, you've got these sensory nerve branches that have to travel all the way from your spinal cord, wrap around your torso, and then literally punch through the fibrous fascia and the muscle tissue of your abdomen.
Just to reach the skin.
Right. And sometimes, usually at the outer edge of that rectus abdominis muscle or near a surgical scar, the opening the nerve passes through is just way too tight.
Oh, I see.
The nerve gets pinched.
Yep.
It's almost like kinking a garden hose.
Oh, wow. That would cause a really sharp focal pain, I imagine, because you're cutting off the nerve's ability to transmit normally.
Exactly. And the sources also point to myofascial trigger points as another primary culprit for this specific kind of anterior wall pain.
Trigger points,
Yeah.
like a muscle knot.
Yeah, but a really severe one. A trigger point is defined in the literature as a discrete, focal, hyperirritable spot. It sits within a taut band of skeletal muscle fibers.
Like a knot that just refuses to let go.
Right. But there's actually way more happening on a microscopic level than just a tight muscle.
What do you mean?
Well, the cellular environment inside that knot is actually in a state of metabolic crisis.
Crisis.
Yeah. These trigger points are associated with local ischemia, which means the blood supply is severely restricted. And because the blood flow is cut off, you get hypoxia, a massive lack of oxygen in the tissue.
Oh, wow.
The medical literature even notes that the pH level drops significantly in these exact spots.
So the tissue is basically marinating in its own acidic waste products because the blood can't flush it out?
Yes, exactly.
That sounds incredibly toxic.
It is. And the standard treatment for this toxic microenvironment is a trigger point injection.
Right, where a doctor just injects a local anesthetic or maybe a corticosteroid directly into that hyperirritable spot.
Exactly. The injection delivers the specific medicine needed to force that taut band of muscle to relax, which, restores the blood flow and resets the nerve.
Okay, but I have to play devil's advocate here for a second.
Go for it.
If a patient is already experiencing this really sharp, highly focal, ischemic pain in their abdomen,
Yeah.
poking them with a needle feels a bit like trying to put out a fire with a flamethrower, right? I mean, you're introducing a puncture wound to an area that is literally already screaming in pain.
Yeah, it's a totally counterintuitive process. The
Mm.
medicine is the water that puts out the fire, but the delivery vehicle, the needle itself, has to forcefully penetrate the skin, the subcutaneous fat, and the anterior fascia just to get to the muscle. Right,
Ouch!
yeah. That mechanical tearing of tissue causes a new, distinct, and very sharp pain on top of the old pain.
The cure hurts before it heals.
Exactly. But if you look through these Blue Cross Blue Shield policies, there's this really fascinating detail.
Oh, good.
Under their guidelines for non-pharmacologic treatments of this myofascial pain, they specifically list the application of ice or spray cooling as valid therapies.
Okay, that's interesting. So that detail is our first major biological clue then.
Right. The medical establishment recognizes that the specific nerve tissue in the anterior wall responds favorably to temperature manipulation.
Which perfectly opens the door to our main question. How do cooling and vibration actually intercept those pain signals from the needle before they reach your brain?
So let's look at the physics of cold first. Clinically, it's known as cryoanalgesia.
Cryoanalgesia, got it.
Yeah, this involves using ice packs, cubed ice, or vapor-coolant sprays. You know, those freezing sprays you often see used in sports medicine.
Oh yeah, like when a soccer player gets kicked in the shin and the trainer runs out and sprays them.
Exactly. So when you apply cold directly to the skin, you trigger this whole cascade of cellular events. It causes temporary vasoconstriction, which narrows the blood vessels, and it physically decreases the local cellular metabolism.
Okay, I mean, that makes total sense for reducing inflammation, but how does that stop the sharp prick of a medical needle?
So the critical mechanism here lies in your nerve fibers. Your peripheral nervous system basically uses different types of, let's call them cables, to send signals to the spinal cord.
Cables. Okay, track it.
We really just need to look at two specific types, A fibers and C fibers.
Okay.
A fibers are myelinated. That means they have this fatty insulated sheath wrapped around them.
Kind of like the rubber coating on a high-speed copper wire?
That is the perfect analogy, yes.
Yeah.
That insulation allows signals to travel incredibly fast.
Okay.
And A fibers are responsible for transmitting non-painful sensations, things like light touch, vibration, and temperature changes.
Like the cold spray.
Exactly. C fibers, on the other hand, are unmyelinated. They don't have that insulation.
So they're slower.
Much slower. And they are the ones specifically responsible for carrying the sharp, aching, throbbing sensation of actual tissue damage.
Like a needle puncture.
You got it.
Okay, so by applying cold or vibration to the skin, we're intentionally stimulating those really fast insulated A fibers.
Right.
But wait, if we're just sending a cold signal down the fast cable, why does that stop the brain from registering the pain signal that's traveling down the slow C fiber cable? Shouldn't we feel both?
That is the big question. And to understand the interaction between those two cables, we have to look at the gate control theory of pain.
I think I've heard of this.
It was proposed back in 1965 by these two researchers, Ronald Melzack and Patrick Wall. And this theory fundamentally shifted our entire understanding of neurology.
What did they find?
They discovered that pain signals don't just travel on a one-way, uninterrupted track from your skin to your brain.
Ah, so the signals have to pass through a checkpoint somewhere.
Exactly. They meet at the dorsal horn neurons in the spinal cord. You can basically think of the dorsal horn as a processing center. Melzack and Wall proposed that there is a literal neurological gate here. When this gate is open, pain signals flow freely to the brain. But when the gate is closed, those signals get blocked.
Wait, so is this like when a magician distracts you with a flashy move in one hand while doing the actual trick with the other hand? Like, are we just distracting the brain?
Biologically speaking, yes, that analogy is surprisingly accurate. The spinal cord gets distracted. Think of it like a bouncer at a really crowded nightclub.
Oh, I like this.
Right. The dorsal horn is the front door of the club. Those fast, myelinated A fibers that are carrying the sensation of cold or vibration, they're the VIPs.
Okay, and they move incredibly fast and demand immediate attention from the bouncer.
Exactly. And the bouncer has a limited capacity for how many signals he can process at any given microsecond.
Oh, I see where this is going. So when you apply a vibrating massager or an ice pack to your skin just before the needle goes in, you are basically swarming the front door of the nightclub with VIPs.
You're rushing the door.
Yeah. The bouncer is completely overwhelmed processing all these fast-moving vibration and cold signals. So by the time the sharp needle pain actually arrives on the slower C fibers,
The bouncer's just too busy. The C fibers are stuck at the back of the line.
the gate is closed.
The gate is closed. The physical puncture of the tissue is still happening, obviously, but the spinal cord physically cannot process the C fiber transmission, so it just drops the signal.
That's wild. So your brain registers the heavy buzzing or the intense cold, but the sharp pinch of the needle simply fails to compute.
Exactly. It's a phenomenal biological loophole.
It really is. But, I mean, theory is one thing, right? Clinical application is a whole other beast.
Very true.
A skeptic might look at this and say, why go through all this trouble with buzzers and ice packs? Just use a topical numbing cream and call it a day.
And that's a fair question, but we really have to look at the data on creams to understand why they fall so short, specifically for the anterior wall.
Right. Because the limitations of topical anesthetics are actually pretty severe when you're dealing with deep tissue.
Very severe. One of our sources is a clinical study from the KBB Forum. They evaluated Botox injections for masseter muscle hypertrophy.
That's the large muscle in your jaw, right?
Yep. The researchers compared a widely used medical-grade numbing cream called EMLA against a simple vibratory anesthetic device.
Yeah, I was looking at the pharmacokinetics of that EMLA cream in the study. The human skin, specifically the stratum corneum, is evolutionarily designed to be a barrier.
Right. It's supposed to keep the outside world out.
Exactly. So for the EMLA cream to penetrate just 1 to 2 millimeters deep into the skin, the patient literally has to sit there with the cream applied for 45 to 60 minutes.
And it gets worse. To push that anesthetic down to a depth of 6 millimeters, the literature notes you would have to wait 3 to 4 hours.
3 to 4 hours, which completely disqualifies it for our mission today. We already established that an anterior wall microinjection is targeting the rectus abdominis muscle or the deep fascia surrounding it.
Right. It's not superficial.
We're not just scratching the surface of the skin. A patient would have to sit in a waiting room for half the day with cream on their stomach just to numb the upper layers of fat.
And the needle would still hurt once it hit the muscle fascia anyway.
Exactly.
So topical creams are really only designed for superficial dermal procedures. For deep muscular injections, they're just anatomically inefficient.
Which brings us back to that masseter jaw study.
Right. So the masseter muscle sits roughly 5 millimeters below the skin. The researchers used a split-face study designed to test the cream against vibration.
Split-face designs are great for isolating variables because you have the exact same patient, same day, same anxiety levels.
Yep. So one side of their jaw gets the EMLA cream applied 45 minutes before the injection. The other side gets zero cream, just the vibration device applied at the exact moment of the injection.
And what happened?
The statistical analysis showed no significant difference in the pain scores between the two sides.
Wow.
Yeah. The mechanical vibration blunted the deep muscular injection pain just as effectively as the pharmaceutical-grade cream.
The workflow implications there are just staggering. Like, the patients reported a 61% preference for the vibration side for their next visit.
And they didn't prefer it because it numbed them better.
No, they preferred it because it was instant. You bypassed the 45-minute waiting room purgatory entirely.
It's a massive upgrade in patient experience. And we see this exact same efficacy in highly sensitive surface areas, too.
Really?
Yeah, the Journal of Clinical and Aesthetic Dermatology, JCAD, they published a meta-analysis looking at dermal fillers, specifically lip injections.
Oh, man, the lips are incredibly dense with nerve endings,
Highly vascularized.
which makes any puncture there just agonizing.
Totally. But using a device called the Vibrata, 95% of the patients in the study reported a significant reduction in pain compared to a standard injection.
95%.
Yeah. On a 10-point pain scale, the average score dropped from a 5.6 down to a 3.82.
That's a nearly 2-point drop just from introducing competing mechanical noise to the area. I mean, that proves the gate control theory works even in highly sensitive tissue.
Absolutely.
But what happens when we pit vibration directly against cooling? Like, which one is actually better?
That's a great question. And to find the absolute ceiling of pain management, researchers actually often turn to pediatric dentistry.
That makes sense. Children are obviously highly reactive to pain.
Yeah, and palatal injections, which is injecting anesthetic directly into the roof of the mouth, are notoriously brutal.
Ugh, just thinking about that hurts. The tissue on the roof of the mouth is stretched so tight across the bone, there's like no loose fat for the injected fluid to expand into.
Exactly. So the fluid physically tears the tissue layers apart as it enters. It's intense pressure.
So what did the studies show?
We have two really fascinating studies evaluating this exact procedure. A study from Mansoura University compared a specific vibration tool called the dental vibe against pre-cooling the tissue with ice. Their data concluded that vibration significantly beat the pre-cooling in lowering the children's pain scores.
Okay, but wait, then I look at the study published in the International Journal of Contemporary Medical Research, the IJCMR.
Right.
They tested 4 distinct methods on the palate: a topical gel, buffered anesthesia, mechanical vibration, and cubed ice. And their data actually flips the conclusion slightly.
It does. But first off, both cooling and vibration utterly demolish the topical anesthetic gel's ineffectiveness.
Which tracks with everything we've talked about.
Yeah. But the IJCMR data showed pre-cooling slightly edging out the vibration. On the Wall-Baker Faces Pain Scale, pre-cooling scored a 2.4, while vibration scored a 2.6.
I mean, a 2.4 versus a 2.6 is essentially a statistical photo finish.
Yeah, it's incredibly close. The discrepancy could literally just come down to the specific vibration devices they used in the different clinics, or just the subjective nature of pediatric pain reporting.
Right. So the underline and takeaway for anyone listening is that whether you use a buzzing tool or an ice cube, you're performing a biological hack that vastly outperforms standard numbing gels.
Exactly. And we can prove this hack extends to the deepest, most aggressive forms of medical pain, too.
Like what?
Well, the journal Agent published a study involving patients receiving intravenous propofol and rocuronium.
Okay, for context for the listener, propofol is a general anesthetic used to put patients to sleep for surgery.
Right.
But it's a lipid emulsion, and as it travels up the vein, it directly activates pain receptors in the vein walls. Up to 80% of patients report intense burning.
It's awful. And rocuronium is often administered right alongside it as a muscle relaxant.
Yeah.
And because of its specific pH and osmolarity, it's highly acidic to the veins. It often causes these severe involuntary withdrawal movements from the patients just because the burning is so intense.
It's a deep chemical fire inside the bloodstream. So how did they test vibration against that?
The researchers simply applied a standard T-shaped vibration massager to the patient's hand 1 minute prior to pushing the IV drugs.
Just a massager on the hand.
Yep. And in the control group, with no vibration, only 3.8% of patients felt zero pain.
Huh?
In the vibration group, the number of patients who felt absolutely zero pain skyrocketed to 28%.
Wow. Jumping from under 4% to 28% feeling nothing for a chemical burn, that is incredible.
Right. And there's another study in the JCAD meta-analysis that looked at deep intramuscular antibiotic injections in the gluteal area.
Okay.
They compared a continuous vibration massager against a physical plastic tool called the shot blocker.
I've seen those. It uses small, blunt contact points to press firmly into the skin.
Exactly. It's meant to confuse the nerves with static pressure.
It sounds like the shot blocker is trying to use the gate control theory too, right?
Yeah.
By sending non-painful pressure signals to the bouncer?
Yes, it is.
So I compare the two.
Because of sensory adaptation. If you press a blunt piece of plastic into your skin, your nerves register the pressure initially. But very quickly, your nervous system adapts to that static feeling and just stops sending the signal.
Oh, so the VIP line dries up and the bouncer goes back to letting the C-fiber pain signals through.
You got it. And that's why the continuous vibration group had significantly lower pain scores than the shot blocker group, because the mechanical buzzing constantly forces new shifting signals down the A fibers.
The bouncer never gets a chance to adapt.
Exactly.
So we've explored the anatomy, the cellular biology, the neurological gatekeepers, and all these clinical trials. Let's synthesize all of this and return to our main mission for today.
Let's do it.
You're scheduled for an anterior wall microinjection to treat a painful abdominal trigger point. Can you use a vibration device or a localized cooling system to blunt the sharp needle sensation?
Based on the totality of the evidence, the answer is an absolute yes. When we look at the anatomical depth of the rectus abdominis muscle, we know for a fact that waiting for topical numbing creams to penetrate that skin barrier is just clinically impractical and inefficient.
Right. And we also have the structural validation from the insurance policies. Blue Cross Blue Shield explicitly acknowledges cooling as a valid, non-pharmacologic treatment for myofascial pain.
Which proves that the localized nerve tissues in the anterior wall are highly receptive to temperature manipulation.
Exactly.
And finally, we have the mechanistic validation from across the entire medical field, from highly vascularized lip fillers to deep intramuscular antibiotics and chemically burning IVs.
Both continuous mechanical vibration and cryoanalgesia successfully exploit the gate control theory.
Yes. They flood those fast-moving A fibers, they overwhelm the dorsal horn neurons in the spinal cord, and they literally block the slower C fiber pain signals from ever reaching the brain.
So the actionable takeaway for you listening is actually incredibly straightforward. You can confidently purchase an inexpensive, reusable handheld massager, or, honestly, simply bring a cold pack to your doctor's appointment.
Yeah, it's that easy.
By applying either of these directly near the injection site, just seconds before the procedure, you take active control of your pain management.
Exactly. You don't just have to grit your teeth, grip the sides of the exam table, and just passively endure the puncture.
It totally removes that feeling of helplessness from the medical experience.
It really does. But, digging into the actual mechanisms of the gate control theory leaves us with a much broader, fascinating concept to ponder.
Oh, what's that?
Well, we've proven that the simple application of a targeted mechanical vibration, just a tiny buzzing motor, can literally trick the spinal cord into ignoring the severe physical trauma of a puncture wound.
Right. We proved that the neurological bouncer can be easily distracted by a loud enough crowd.
Exactly. Which begs the question, exactly how vulnerable is our perception of reality?
Oh.
It highlights this deeply subjective, almost malleable nature of human suffering. I mean, if our neurological processing gates can be so easily jammed by a tiny buzzing motor,
Yeah.
what other negative physical or even emotional sensations might we be able to intercept and turn off simply by introducing the right kind of harmless competing noise into our nervous systems?
That is a brilliant question to leave on. Next time you see that medical needle coming, remember that your biology is a system, that system has a loophole, and you hold the key to exploiting it. Thanks for joining us on this deep dive.